The next set that we're going to jump into is the muscular dystrophies. And when we look at muscular dystrophy, this is a term that's composed of several genetic disorders characterized by these pathologic changes within muscles that affect the limbs, the face, sometimes respiratory, or even the cardiac muscles. They are distinguished from the other neuromuscular disorders in that they are primary myopathies, are progressive, and manifest degeneration of muscle fibers pathophysiologically and have a genetic origin. So these have something that's a little bit different than the previous neuromuscular disorders that we've been talking about. Muscular dystrophies may manifest at different times throughout life with different degrees of severity. So these disorders can be transferred as dominant genes or recessive genes or X-linked traits, and they're typically sporadic in cases. One of the most common muscular dystrophies that we will talk about is this Duchenne muscular dystrophy, or DMD. This is the most common inherited neuromuscular disorder. Duchenne muscular dystrophy is inherited as an X-linked recessive trait, which means that males are more likely to get it than females. Even though males are more likely to have DMD, some women are actually asymptomatic carriers. When we look at Duchenne muscular dystrophy, this is an X-linked recessive gene that typically sees onset about 1 to 3 years of age. And when we look at the skeletal muscle involvement, you get proximal muscle weakness, and the lower limbs are affected first, following by the upper limbs and then the distal muscles. Patients are going to show up with cardiomyopathy, intellectual impairment, seizures, autism-like behavior, and even respiratory failure. Typically, these patients will live about 40 to 50 years. When we look at the myotonic dystrophy, this is an autonomic dominant gene that is impacted. Typically, we see the onset of this disorder childhood to early adult, depending on the size of the impairment. So when we look at the myotonic dystrophy, there's two different types. It's labeled as type 1 and type 2. These patients are going to appear with cardiac arrhythmias, hypersomnia, excessive daytime sleepiness, hypogonadism, dysphagia, gallbladder disease, cognitive dysfunction, cataracts disease, abnormal liver function, and premature balding. When we look at the life expectancy, with type 1 it's mildly reduced, but with type 2 you have a normal life expectancy. When we look at Emery-Dreifuss muscular dystrophy, this is going to be a X-linked recessive gene, or it could be the autosomal dominant or autosomal recessive. So it could be all three, but typically the autosomal recessive is very rare. We see this happen between the ages of 5 and 15. These patients are going to present with dilated myocardiopathy, arrhythmias, and even strokes. So when we look at these patients, their life expectancy is typically variable. When we look at the limb-girdle muscular dystrophy, this is going to be your autosomal dominant and your autosomal recessive genes. This happens somewhere between childhood to adulthood. You're going to have cardiomyopathy and arrhythmias, and their age range is going to be variable as well. When we look at this last one here, this is going to be a autosomal dominant gene. This typically happens late in childhood or in middle adulthood. These patients are going to show up with arrhythmias, cognitive impairment, hearing loss, epilepsy, and even pain. But when we look at the life expectancy for these patients, it's going to be normal. So 1, 2, 3, 4, 5 different types of muscular dystrophies. You might want to familiarize yourself with age ranges, signs and symptoms, and life expectancy. When we look at the diagnostics for muscular dystrophies, we have a combination of physical exam, of lab testing, and muscle biopsy findings. So your clinical findings are typically going to be muscular weakness, fatigue, muscle wasting, dysphagia. So a thorough family history should be evaluated when muscular dystrophy is suspected. When we look at our laboratory testing, we're going to look at the creatine kinase and the atolase. These are proteins that will show up that suggest muscular damage. So we want to make sure that we are evaluating these additional tests when we are suspect of muscular dystrophy. When we talk about the clinical findings, we've already talked about it some, but that muscular weakness, that fatigue, muscle wasting, and dysphagia. So if we have that dysphagia, should prompt an evaluation for any of these myopathic disorders. When we jump into this, the management, there's really no cure for muscular dystrophies. We can reduce some of the inflammation that appears with these disorders with corticosteroids, but the downside is there's an increased weight gain, there's behavioral abnormalities, you can get excessive hair, it diminishes your bone density, so you end up with osteomyelitis, poor wound healing, and poor glucose control. So when we talk about management, some of the things that we can do is we can be on an anti-inflammatory diet as well. So that anti-inflammatory diet can only help when it comes to maybe even decreasing the amount of corticosteroids that we have. But additional therapies that we want to look at are physical and occupational therapy. We can even do gene therapy. This is still going through and getting a lot of research still. There's still the jury's out whether or not this is going to be a viable option for muscular dystrophy or not. And then we can make sure that we are monitoring any of the pulmonary complications that could be associated with it, like respiratory muscle weakness, an impaired cough, vent failure, or even congestive heart failure. So these patients are going to eventually potentially need non-invasive ventilation or even invasive ventilation for their for their respiratory failure. They could have atelectasis and pulmonary infiltrates just from that respiratory weakness. That could use some airway clearance therapy. These patients are going to have some congestive heart failure. So utilizing our PEEP or our CPAP, our EPAP, greater than 10 to 12, FiO2 greater than 50%, we can use beta blockers or ACE inhibitors, and we want to make sure that we're monitoring that salt and fluid intake. These patients are going to be at an increased risk for arrhythmias, so they may be on medications for antiarrhythmics. And then there's the end-stage cardiomyopathy, and we can end up with what's called a ventricular assisted device, or a VAD. And these patients could ultimately end up with a heart transplant. So these patients that have muscular dystrophy will come in and they will need our assistance. So we need to make sure that we are aware of the different types and when the onset is, so that we can take care of these patients in the event of respiratory failure. It's going to be one of those things where we identify impending ventilatory failure or acute ventilatory failure with these patients. So we just need to make sure that we are on top of our game when it comes to the assessment of oxygenation and ventilation. When we get into EKGs and we understand a little bit more with the arrhythmias, we can start to hammer those out a little bit with the medications. But CHF is definitely one that we have talked about before, and we know how to handle those patients as well.